picture this. You are sitting in the glow of your phone screen at 2 in the morning.
Oh, we've all been there.
Right. And you are thinking about starting a family.
Mm-hmm.
Or maybe, you've just seen that little plus sign on a pregnancy test.
Which should be this moment of just absolute joy.
Exactly. It should be joyous, but instead you find yourself completely terrified. Because you, or maybe someone you really love, has been diagnosed with lichen sclerosus.
Yeah.
And I mean, when you type that diagnosis into a search engine right alongside the word pregnancy, the internet just suddenly becomes a very, very dark place.
It really does. It's overwhelming.
It is. You get absolutely bombarded with all this medical terminology like scarring and tearing and introital stenosis.
Terrifying words for anyone to read late at night.
So terrifying. And it all just sort of culminates in this one massive looming question, which is, can you even have a normal vaginal delivery with lichen sclerosus?
And, that fear is entirely rational, especially when you just look at the surface level stuff available online.
Right, because the internet loves extremes.
Oh, it thrives on them. It tends to present medical conditions in these massive extremes. Like either you have absolutely nothing to worry about or, you are facing this guaranteed medical emergency.
But the reality has to be different, right?
Oh, yeah. The biological reality of managing a chronic skin condition during childbirth is just far more nuanced. And when we actually look at the clinical outcomes, the picture is considerably more hopeful than those late-night searches would lead anyone to believe.
Well, today, we are going to put those late-night forum fears to rest. Because our mission in this deep dive is to answer that exact question.
Yeah.
Can lichen sclerosus affect vaginal delivery? And if it can, how do you actually navigate it safely?
And we are not just, guessing here.
No, absolutely not. We aren't relying on random anecdotal message boards. We have pulled together decades of rigorous clinical data.
The good stuff.
The very best. We are looking at the 2014 UK National Guideline from the British Association for Sexual Health and HIV. We've got the updated 2021 European Guidelines. Plus, we are bringing in some really comprehensive clinical insights from both the Women's Health Clinic and the NHS.
And that amazing review, too.
Yes, exactly. A highly detailed medical review of 33 pregnancies in women with lichen sclerosus. And that was conducted by researchers Nguyen, Bradford, and Fisher.
Synthesizing all these international guidelines with, localized clinical data, it just provides this remarkably clear roadmap.
Right.
It allows us to basically move past the anxiety of the total unknown and look at what expectant mothers can actually anticipate on a biological level.
I love that. So I think we should just establish the headline right up front for the listener.
Let's hear it.
The short answer to whether you can have a vaginal delivery with lichen sclerosus is yes.
Yes, absolutely.
You absolutely can. But, the mechanics of making that happen safely, the biological how and why, that is the real story here today.
It really is.
So before we jump right into the delivery room, we sort of need to understand the physical baseline we are working with, right?
Right. We have to set the stage.
For those who actually live with the condition, the intense, sometimes just totally debilitating itching is a known daily reality. But on a cellular level, what is happening? Because lichen sclerosus is it's a chronic inflammatory skin condition heavily linked to autoimmune factors.
Exactly. The body's immune system essentially misfires. It gets confused and targets its own tissue, specifically right in the anogenital region.
And that immune misfire is the crucial part, isn't it?
It is. The inflammation basically attacks the basement membrane zone of the skin, and as a result, the skin loses its normal elasticity.
Okay.
It stops producing healthy collagen in the way it should, so it takes on this very pale, often crinkled appearance.
Like I saw in the dermatological terms, it's frequently described as resembling cellophane paper.
Yeah, cellophane or parchment paper. And it often manifests in this really distinct figure-of-8 pattern that encircles the vulva and the perianal area.
And okay, that parchment description, that is precisely where the fear for expectant mothers takes root. Yeah. Because parchment paper does not stretch.
No, it definitely does.
And the clinical sources we looked at, they frequently warned about this concept called loss of architecture.
Yeah, that's the clinical term for it.
Right, which in plain terms means that when this chronic inflammation just goes unchecked, it triggers a really destructive scarring process.
Exactly.
Like the inner lips, the labia minora, they can shrink or even resorb completely. The tissues can literally fuse together.
The clitoral hood can seal over, too.
Wow. And most critically for childbirth, it can cause introital stenosis, which is basically this severe narrowing and total loss of flexibility right at the vaginal opening.
Yeah, the structural changes you're describing are profound.
Yeah.
I mean, when tissues fuse and narrow like that, the basic anatomical requirements for a traditional delivery are totally compromised.
Which leads us to what I call the unavoidable mechanical paradox
I,
here.
I like that term.
Because think about it. A vaginal delivery requires maximum elasticity, right?
Absolutely.
The tissue has to perform this incredible, extraordinary biomechanical feat to allow a human head to pass through it. So, if lichen sclerosus turns the skin into this fragile, tight parchment paper that is super prone to fusing and tearing under even just minor stress, how on earth is a vaginal delivery not universally contraindicated?
It sounds impossible.
It does. It seems like applying Olympic-level stretching forces to parchment paper would just result in catastrophic tearing.
And that paradox is exactly why this topic causes so much anxiety. It seems entirely counterintuitive.
Right.
And, we should be really clear here. If a patient presents with severe, completely unmanaged lichen sclerosus featuring extensive, rigid scarring that has permanently narrowed the vaginal opening.
Right, the extreme cases.
Exactly. In those unmanaged cases, a natural delivery does pose significant risks, and obstetricians will often just plan for a cesarean section.
Okay.
However, the European and UK guidelines are incredibly emphatic on this one point. The mere presence of lichen sclerosus is not a contraindication for a vaginal delivery.
That is so huge, meaning the diagnosis itself doesn't just automatically lock you out of a natural birth.
Not at all.
So the key variable really is the state of the tissue at the specific time of delivery.
Yes. That parchment paper texture, the extreme fragility, those aren't permanent, irreversible states for every single patient.
Okay, that's a relief.
Right. They are the direct result of active, ongoing inflammation.
Active inflammation. That is a vital distinction. So when a patient effectively suppresses that active inflammation, the tissue can bounce back.
Exactly. The underlying collagen and elastin in the dermal layers can actually function relatively normally again. The skin regains a really significant portion of its resilience.
Wow.
So the goal isn't necessarily to magically cure the entire condition before birth. It's to transition the tissue from an active, inflamed state to a managed, pliable state.
Pliable, I love that word for this. Which perfectly brings us to the complexities of actually managing this condition while you were pregnant.
Right, because pregnancy throws a wrench into everything.
It totally does. Pregnancy alters the biological landscape entirely. Hormones are surging everywhere, blood volume increases, and, well, most importantly, the immune system undergoes a massive shift.
It really does.
So we have to look at how pregnancy actually alters the trajectory of lichen sclerosus itself.
The interaction between pregnancy and autoimmune-linked conditions is honestly one of the most fascinating areas of immunology.
I found it fascinating, too.
Yeah, and the sources highlight some highly reassuring data on this front. For instance, there's a study highlighted by the Lichen Sclerosus Guide that tracked 85 pregnant individuals with the condition.
Okay, 85 people. What happened?
Out of those 85, a really significant majority, 65 people, actually saw their condition remain completely stable throughout the entire 9 months.
Okay, wow, that's huge.
Right. And it gets better. 12 patients actually saw their symptoms improve dramatically.
Wait, they got better?
Yeah, improved dramatically. And only 7 reported that their condition worsened.
Only 7 out of 85 got worse. So the vast majority either stayed completely stable or experienced real relief.
Exactly.
And when we look at the underlying immunology of that, it actually makes perfect biological sense.
Because of the shift, right.
Right. During pregnancy, the body has to tolerate a fetus that is essentially a semi-allograft. I mean, it contains foreign paternal DNA.
Right. Half of it is totally foreign to the mother's body.
Exactly.
Yeah.
So to prevent the mother's immune system from just attacking the fetus, the body naturally dials down certain inflammatory immune responses.
It's so smart.
It creates this state of immune tolerance.
Yeah.
And because lichen sclerosus is driven by an overactive immune response, this temporary systemic immune suppression acts as like a natural buffer.
Right. It calms the inflammatory triggers that cause those awful flare-ups.
Yeah.
And the cellular mechanisms behind this are just remarkable. You have these things called regulatory T cells.
Okay.
They basically act as the peacekeepers of the immune system, and they increase exponentially during pregnancy.
Peacekeepers, I like that.
Yeah. They literally secrete anti-inflammatory signals that tell the surrounding immune cells to just stand down.
Back off, basically.
Right. So for a patient with an autoimmune-driven skin condition, this systemic bath of anti-inflammatory signals creates a highly favorable environment for the skin to rest and, to maintain its elasticity.
That biological buffer is a massive relief. But it introduces a really complex treatment dilemma for the patient.
The medication question.
The medication question, exactly. Because the universal advice given to pregnant people is to treat their body like this highly restricted temple.
Right, absolutely. Don't eat this, don't do that.
Right. You avoid specific foods like deli meats, you completely overhaul your skincare routine, and you certainly avoid intense medications.
Yeah.
Yet, the absolute gold standard treatment for halting the inflammation of lichen sclerosus is the use of ultra-potent topical steroids, like clobetasol propionate.
Which sounds scary to a pregnant person.
It really does. The immediate instinct for so many patients is to just stop using these powerful steroids the very moment they see a positive pregnancy test.
And yielding to that instinct is arguably the most dangerous misconception surrounding this entire condition.
Wow, really?
Yes. The clinical guidelines from both the UK and Europe are absolute on this. Limited amounts of potent topical steroids are completely safe to use throughout pregnancy and breastfeeding.
Completely safe. But why? The hesitation usually stems from a misunderstanding of how the medication is actually delivered to the body, right?
Exactly. People think of oral medications.
Right, like a pill. When you take a pill, it is absorbed systemically. It enters the whole bloodstream, travels throughout the entire body, and crosses the placenta directly to the fetus.
Right.
But topical steroids used for this condition, they function entirely differently. You are applying a really minute amount of ointment to a highly specific, very localized surface area of the skin.
It's all about localization. The medication binds to the glucocorticoid receptors right in the local dermal layers, so it shuts down the inflammation right there at the source.
Oh, I see. So it's not circulating everywhere.
Exactly. The localized delivery is everything here. The systemic absorption, meaning the actual amount of steroid that makes it past the local skin tissue and into the maternal bloodstream, is just minimal.
Okay.
It is clinically insignificant for fetal development.
Which means that stopping your steroid treatment out of this generalized fear of medication is actively harming your chances of a safe vaginal delivery.
Right, 100%.
Because if you withdraw that localized steroid, the inflammation just roars right back.
It comes back with a vengeance.
And then the tissue reverts to that fragile, scarred parchment state we talked about, which is entirely unprepared for the mechanical stress of childbirth.
Which is exactly what you don't want. But, the guidelines do draw a very hard line on secondary treatments.
Oh, right.
While localized topical steroids are totally safe, other treatments are absolutely contraindicated.
Yes, the guidelines are very strict regarding alternatives. I saw that topical calcineurin inhibitors, like tacrolimus, are advised against.
Right.
Because unlike steroids, they suppress the local immune system through a completely different chemical pathway. And their safety profile regarding systemic absorption during pregnancy just hasn't been established yet.
We just don't know enough. And even more critically, oral retinoids are strictly forbidden.
Strictly forbidden, because oral retinoids are these incredibly powerful systemic vitamin A derivatives that forcefully alter cell turnover everywhere.
Yeah, they are highly teratogenic.
Which means they have a profoundly high risk of disrupting fetal development pathways. They can cause severe birth defects.
Very severe.
They are so dangerous for a developing fetus that patients are actually advised to stop taking them up to 2 years before even attempting to conceive.
So the protocol is very clear here. Maintain the topical steroid and absolutely discard the systemic alternative.
Right.
And when a patient adheres to that protocol, they really set the stage for the delivery room.
Okay, so let's look at what actually happens inside the delivery room when that protocol is followed. We have the theoretical guidelines telling us it's safe, but we really need to look at the hard evidence of actual births.
The real-world data.
Yes, and this is where that retrospective study by Nguyen, Bradford, and Fisher becomes just invaluable. They reviewed 33 actual pregnancies in women who had biopsy-confirmed lichen sclerosus.
And the data they gathered is incredibly validating for expectant mothers.
Tell me the numbers.
Out of those 33 documented pregnancies, 27 resulted in spontaneous vaginal births.
Wow.
Yeah, that is an 82% success rate for unassisted vaginal delivery.
82%. That is a remarkable statistic, especially when you contrast it with the overwhelming pessimism you find on those internet forums at 2 a.m.
Exactly. It proves that proactive management really, really works.
It really does. But what about the other cases in the study?
Well, the details of the remaining cases actually further reinforce this whole point. Two women required instrumental deliveries, meaning forceps or a vacuum, were
What?
utilized. But the medical records indicate those interventions were for standard obstetric reasons.
Like fetal distress.
Exactly, like fetal distress. They were entirely unrelated to the underlying skin condition.
Okay, but we also have to address the 4 cesarean sections out of that 33 patient cohort.
Right, the C-sections.
Because the critical detail here is that only one of those 4 C-sections was specifically necessitated by severe, unmanaged lichen sclerosus that presented with heavy scarring.
Just one.
Just one. And the clinical notes indicated that this specific patient was actually non-compliant with their steroid medication.
There it is.
The data continually points right back to the fact that maintaining the medication is the exact thing that keeps your delivery options open.
It is the absolute key. But, while the data supports this high probability of a successful vaginal delivery, it doesn't eliminate the regular biomechanical realities of childbirth.
Right, giving birth is still giving birth.
Exactly. Tearing remains a primary concern. Even with perfectly managed lichen sclerosus, patients just fear that their skin simply won't withstand the stretching forces.
And it is a totally valid fear. But we have to contextualize it within standard obstetrics. I mean, up to 90% of all first-time mothers experience some degree of vaginal tearing during birth anyway.
Yes, regardless of their dermatological health.
Right. The tissue is literally stretching to its absolute biological limit.
And that elasticity is the core issue here. Because even a well-managed patient with lichen sclerosus has tissue that doesn't quite possess the exact same tensile strength as completely unaffected skin.
Makes sense.
Consequently, natural perineal tears, or the medical necessity for an episiotomy, which is a controlled incision made by the doctor to widen the vaginal opening, are just statistically a bit more likely.
And recovering from an episiotomy or a severe tear is difficult for anyone. But recovering when you have a chronic autoimmune skin condition introduces this highly specific complication.
The Koebner phenomenon.
Yes. I was analyzing the clinical insights, and there is this fascinating yet deeply concerning warning regarding the Koebner phenomenon.
It's wild, isn't it?
It is. From a cellular perspective, this is essentially a biological glitch. It's where physical trauma, like a natural tear or a surgical cut during birth, actually tricks the immune system into triggering a brand new flare-up directly on the healing scar tissue.
Yeah.
It feels like a cruel biological irony. You're trying to heal, and your body attacks the wound.
It really is. The Koebner phenomenon, it's also known as the isomorphic response. It was actually first identified way back in the 19th century by a dermatologist named Heinrich Koebner.
Oh, interesting.
Yeah, he found it in relation to psoriasis, but it applies heavily to lichen sclerosus too. Basically, when healthy tissue tears, the body sends fibroblasts and immune cells rushing in to rebuild the matrix.
Right, to fix the cut.
But in an autoimmune patient, those rushing immune cells get completely confused by the trauma. So instead of just healing the wound normally, the trauma accidentally initiates that miscalibrated inflammatory cascade that is specific to the disease.
Wow. And in the 33 case study, researchers specifically documented an instance where a perineal scar from delivery was complicated by the development of lichen sclerosus right on the new scar tissue.
Exactly.
Which proves that preventing tearing isn't just about avoiding stitches. It is really about preventing the creation of new disease sites.
Precisely.
Fortunately, the NHS and specialized vulval clinics offer some very actionable biomechanical strategies to mitigate this risk. First off, they highly recommend perineal massage in the weeks leading up to the birth.
Yeah, the biomechanics of perineal massage are really straightforward, but highly effective.
How does it actually work?
Well, by regularly applying mechanical stretching forces to the perineum, the area between the vagina and the anus, you actively increase local blood flow. But more importantly, this regular manipulation actually helps alter the alignment of the collagen fibers over time. It makes them more parallel and just significantly more elastic by the time labor finally begins.
And then during the actual delivery, the technique used during crowning is paramount.
Oh, absolutely crucial.
The NHS guidelines describe a really specific method where the midwife instructs the mother to stop pushing right when the baby's head becomes visible, and instead they switch to these quick, short breaths, essentially panting.
Yeah, guided panting.
Right, and this guided panting acts as a physical break. It stops the rapid forward momentum of the baby and allows the head to emerge at a much, much slower rate.
Giving the tissue time is absolutely essential. By slowing that mechanical force, you give the somewhat compromised collagen and elastin of the perineum the vital minutes they need to adapt and stretch naturally.
Which reduces the tearing.
Exactly. It significantly reduces the sheer stress that causes catastrophic tearing.
Okay, so assuming the birth is successful, you utilize guided panting, the baby arrives safely, and perhaps there is a minor tear that is stitched up. The immediate assumption is that the hard part is over.
Yeah.
You would think so. You would. But diving deep into the clinical sources reveals a massive hidden danger zone in the weeks immediately following the birth. I look at it as the postpartum trap.
It is absolutely a trap, and it's a documented phenomenon with really serious consequences.
Yeah.
If we refer back to that 33-case study by Nguyen and colleagues, they tracked a vital metric, which was medication compliance.
Right. Are they taking their meds?
Exactly. How consistently did the patients actually continue to apply their topical steroids? During the pregnancy, compliance was impressively high. It peaked at 76%.
That's pretty good.
Because expectant mothers are highly motivated, they have frequent medical check-ins, and their focus is totally locked on achieving an optimal delivery.
But the data shows a really stark reversal postpartum. Compliance drops sharply down to just 60%. And honestly, it is so easy to understand why. It isn't just about carelessly forgetting to apply cream. It is a recognized behavioral psychology state akin to cognitive tunneling.
That's a great way to describe it.
Right. I mean, you have just survived a massive physical trauma. You are operating on totally fragmented sleep, your hormones are completely erratic, and you are entirely focused on keeping a fragile newborn alive.
Survival mode.
Exactly. Your brain literally narrows its focus to the most immediate, life-threatening priorities. The proactive, preventative habit of applying a steroid ointment simply drops right off the mental radar.
And it is a completely understandable human reaction to being in survival mode.
Right.
However, biologically speaking, dropping that routine is profoundly dangerous.
Because of the hormones.
Yes. We discussed earlier how the pregnant body maintains high levels of estrogen and progesterone, along with a suppressed immune system, which acts as a buffer for the disease.
Right, the peacekeepers.
Right. But immediately after delivery, those hormone levels crash violently right back to pre-pregnancy levels.
Oh, wow. It is literally like trying to rebuild a house during a hurricane.
That is exactly what it is.
You are trying to heal the physical trauma of childbirth, but that sudden hormonal crash completely removes the anti-inflammatory buffer you've relied on for 9 months.
It's gone.
So if you aren't actively using your topical steroid to manually suppress the inflammation, the immune system just storms right back in and attacks the very tissue you were trying to repair.
And the clinical guidelines issue really severe warnings about this specific window. When the immune system attacks raw healing tissue, especially if there are stitches from a tear or an episiotomy, the scarring process accelerates at just an alarming rate.
That is terrifying.
It is. Without the localized steroid to act as a shield, the inflamed tissues of the vulva essentially undergo uncontrolled wound healing. They can act almost like glue, leading to a rapid refusion of the labia.
The reality is that a patient could endure more severe structural changes in the 6 weeks postpartum than they experienced in the 6 entire years prior to getting pregnant.
Easily.
Which highlights why proactive communication is arguably just as important as the medication itself.
Oh, communication is vital.
The guidelines suggest ensuring your entire healthcare team, and crucially your partner, are fully briefed on your exact treatment plan before labor even begins.
Yes, write it down.
Because when you are deep in that cognitive tunnel of newborn survival, your partner needs to be the one physically handing you the medication and reminding you why it is structurally essential for your recovery.
It requires relentless dedication during a period of just extreme exhaustion. But that dedication is the difference between tissue that heals normally and tissue that suffers irreversible architectural loss.
So let's synthesize exactly what the science is telling us today. If you are sitting in the dark, overwhelmed by medical jargon, the clinical data actually provides a highly encouraging roadmap.
It really does.
Having lichen sclerosus does not preclude you from having a normal vaginal delivery. The medical guidelines support you, and the statistics from actual delivery rooms demonstrate a very high rate of success.
But achieving that success relies on a really clear 3-pillar strategy.
Okay, let's break it down.
First, maintaining consistent, localized use of prescribed topical steroids throughout the entire pregnancy. That ensures the tissue remains supple and free of active inflammation.
Crucial.
Second, utilizing biomechanical preparation like perineal massage and communicating really clearly with your obstetrics team to manage the physical stress of crowning with techniques like guided panting.
And the third.
Third, maintaining strict adherence to your treatment protocol in the chaotic postpartum period. That protects the healing tissue from the inevitable hormonal crash.
It is ultimately about managing the condition so the condition doesn't dictate your birth plan.
Perfectly said.
But, as we look at all this data, there's this underlying immunological concept here that points to something much, much bigger than just managing symptoms.
Oh, you mean the immune tolerance aspect?
Yes, the mechanism of immune tolerance during pregnancy, where the body purposefully dials down its immune responses and floods the system with regulatory T cells to protect the fetus. It is one of the most heavily researched areas in modern medicine.
It's fascinating stuff.
We know that this temporary systemic ceasefire causes conditions like lichen sclerosus to just magically stabilize or improve for 9 months.
Which raises an incredible prospect for the future. Scientists are actually actively trying to decode the exact cellular messaging that tells the pregnant body to safely suppress these inflammatory pathways.
Right. Without compromising the mother's overall health.
Exactly. And if researchers can identify that specific biological mechanism, they could theoretically find a way to replicate it.
Just imagine. If that mechanism could be synthesized and applied permanently, entirely independent of being pregnant, it would fundamentally change the entire landscape of autoimmune medicine.
It would be a total game changer. We wouldn't just be managing active inflammation with localized steroids anymore. We could literally be looking at the biological blueprint for a lasting, systemic cure for lichen sclerosus and potentially a myriad of other autoimmune diseases.
It totally reframes the entire narrative. Pregnancy doesn't have to be viewed solely as a period of fear and medical anxiety for patients with this condition. The very biology of pregnancy might actually hold the key to a future cure.
It's wild to think about.
It really is. So if you find yourself staring at a screen tonight, absolutely terrified by worst-case scenarios, please remember that the clinical data is highly in your favor, the management protocols are extremely effective, and the science is constantly evolving. Your body is vastly more resilient than a late-night search result would ever suggest. Thank you for joining us on this deep dive. Keep asking the hard questions, and we will see you next time.